Okay, I'm going to move straight on. No questions at this point in time. And next, it's my pleasure to introduce Dr. Vivek Rathi. And Vivek is the clinical unit head of the Department of Genetics and Molecular Pathology at Monash Health. And prior to starting earlier this year, he was the supervisor of molecular diagnostics for solid tumours at St Vincent's Hospital in Melbourne. He's contributed to the design and validation of multiple next generation sequencing assays for clinical testing. So he is very well placed to talk to us about the what, when and where of assays. Thanks, Vivek.
Thanks, Ben. I'll start with sharing my screen. Okay, so without much further ado, I'll start. Hello, everyone. In this presentation, I'll share with you some of the important aspects of NGS assays when used in clinical settings, and my talk is just based around somatic mutation testing or cancer genomics today, not germline. So this will include discussion on different types of available NGS assays, their application, and also some important factors that are essential to determine what type of labs are best suited to perform these assays. Lastly, I'll shed some light on the limitations and challenges that come with this work. So commencing with a bit of background, the advent of personalized medicine has been possible due to advances in mapping out the human genome. At present, technologies like NGS are providing us the ability to analyze not only parts of genes, but much more than that, and that too at a fraction of cost and time compared to conventional platforms that we are known to use. So with time, as newer and more specific biomarkers are being developed, the one-size-fits-all medicine is slowly disappearing. This is being taken over by stratified approaches, where along with patients' medical history, genomic alterations are also being seriously considered when oncologists formulate a treatment plan. The future seems to be rapidly moving towards precision medicine, where increasing reliance is being put on genetic signatures of an individual's tumor. And so we can clearly see that molecular diagnostics is causing a paradigm shift in the way we treat and manage various classes of patients and diseases. So be it prenatal testing, where we are trying to find out if the baby is healthy, to disease predisposition or disease detection, drug selection, and all the way to disease monitoring. So this is our local Australian data, and the use of genetic test is obviously increasing at a rapid pace, as visible from this chart. We can see how rapidly genetic test requests are increasing year after year compared to conventional cytogenetic tests, which include microscopy-based FISH and karyotyping. As you can see, in 2006, we had a demand of about 100,000 of these tests, and even in 2016-17, it was around 600,000. So I must say that although this is improving treatment outcomes, it's obviously posing new challenges for the healthcare industry and particularly labs that are involved in these testings. So to be able to practice genomics, we need NGS assays. The reliance on single gene traditional assays is nearly coming to an end, at least in many tumor types, if not all. And this is being replaced by multi-gene assays, which are not only comparable in cost, but also offer several other advantages. So there's a rapid evolution with continuous discovery of new biomarkers and therapeutic targets, which are gradually being transitioned into clinical use. So now let's talk a bit about what type of assays are currently available. So today, with the help of these assays, we can not only perform mutational analysis like single nucleotide variations and indels, which are more common work that we do, but there are a variety of other possibilities which include copy number variations, fusions, RNA expressions, methylation, etc., etc. Now, this allows for a comprehensive analysis of functional effect of mutations, the analysis of various pathways, and thereby supporting integrative analysis, which is paving way for further understanding of various diseases, and actually many clinical applications are emerging. So we have assays available with different design and chemistries, for example, and these are performed on different types of platforms. But having said that, these are all fundamentally related. So for example, we have Illumina machine, the ion torrent next generation sequences, etc., etc. So every platform basically facilitates sequencing of thousands to millions of clonally amplified molecules in a massively parallel manner. So all these platforms depend on principles of clonal amplification, which is done through mostly PCR, and the reaction and the respective reaction output, which could be in the form of luminescence or fluorescence or pH change, can be considered as the signal or noise, which is then converted into a more readable sequencing data. Then there are assays based on applications. We have got DNA sequence change related assays. We work with RNA based assays. We can look at assays that are purely catering to copy number variation, for example, or fusions. We have newer assays now which can do successful RNA expression profiling, and some have started offering methylation also. And then there are some assays that do a lot of this in one assay. For example, the assay on the screen lists various genes that it screens for in various types of tumors. So this is an Illumina TSO500 gene cancer panel, for example. It not only gives us answers for, say, SNPs or indels or fusions, but also screens for tumor mutation burden and microsatellite instability as well. There are assays that can help us do whole exome sequencing or whole genome sequencing, and then there are targeted panels which are more heavily used in clinical setting at the moment. So as the name implies, whole genome sequencing covers the entire genome. Whole exome sequencing is limited to just looking at the exonic regions of, or the coding regions of the genes. And hotspot panels are much lighter. They basically look at very specific spots or hotspots specific to those genes that are included in those assays. I must add that the use of large gene panels like the 500 or 600 gene panels or whole exome or whole genome sequencing in solid tumor setting is still largely reserved as a research tool, and there are many reasons for that, some of which Melissa has just outlined. So there are many advantages of targeted sequencing. These assays, they focus on regions of interest and thereby producing smaller and more manageable data sets. This reduces sequencing cost and data analysis burden. This again has a positive effect on the turnaround times, and we are able to do deep sequencing because of the nature of the assay that also enables identification of variants that are in very low allele frequency, or rarer variants are also detected. Then we have assays with different chemistries, and the two of the chemistries common at the moment, the enrichment methods commonly used at the moment are the amplicon-based and hybridization probes. Amplicon-based sequencing relies on addition of specific amplicons and primers, which facilitates resequencing. Then there are newer hybridization capture-based chemistries now, which depends on DNA fragmentation with probe-dependent hybridization of complementary strands, and thereby helping in sequencing. These come with several advantages and disadvantages in each camp. So for example, hybrid capture method is complex with longer hands-on time in lab with So these methods are complex, longer hands-on time with higher upfront cost, but offer a higher sensitivity, and most importantly, can be used for multiple applications in a single assay. Amplicon-based enrichment process, on the other hand, is relatively straightforward, is faster, with lower upfront cost for the lab. It offers good sensitivity and high specificity, but is limited in the application that it offers. And then there are, these assays can be divided into off-the-shelf panels versus in-house design panels. Again, both coming with their advantages and disadvantages. So let's move on to the topic of when should these assays be performed ideally. So there are a variety of applications ranging from diagnostic to prognostic or predictive to therapeutic. These assays can have many other uses, like analysis of cancer susceptibility genes, methylation, epigenetic changes, gene expression profiling, you name it. So we now know that single gene assessment is increasingly not sufficient in different types of tumors. Many, if not most, tumor types now require assessment of multiple genes. So some of the examples I've highlighted on the screen, for example, non-small cell lung carcinomas, we know that as a minimum, we need answers for EGFR, BRAF, and some of the fusion rearrangement like ALK-ROS, RET, NTRK. Colonic tumors need extended RAS and RAF testing as a minimum. Melanoma, for example, again, minimum expectation is to do at least BRAF and NRAS, and if possible, do GNA11 and GNAC, etc. Some of the thyroid assays cater to not only therapeutic aspects of advanced tumor, but also are diagnostic in many ways. So we know that BRAF and RAS mutations are increasingly being demanded by the treating doctors, but also we know the clinical utility of the RET mutations in medullary thyroid carcinomas. Some of the fusions are very important, like RET-PTC and PAX8. Again, moving on to something like CNS tumors, the WHO 2016 classification of CNS tumors, along with the publication of C-Impact Now guidelines, has changed the way we look at the classification of these tumors now. So now we are classifying them not only based on morphological or histological features, but we are also heavily dependent on molecular signatures as well. So screening for multiple genes and chromosomal alterations has become a must. The C-Impact Now guidelines have introduced many entities with attached molecular signatures, which are actually very important to determining not only the prognostic side of patient's disease, but also treatment. On the same token, there are assays that take into account the expression of various genes to come up with a risk score, as well as help determine appropriate therapy. And a good example of this is the Oncotype DX in the setting of breast cancers. Now, the role of genomic rearrangements and fusion genes have continued to expand at an exponential pace. So it is well known now that fusion events have become diagnostic markers for a variety of tumors, apart from their therapeutic use. And this is very evident in a tumor like sarcoma. So we know that up to 140 odd fusions have been found in sarcomas. And conventional platforms like FISH and PCR are able to only screen for one or two of those fusion partners, not all of them at one go. And so that's where the NGS panels come very handy. Similarly, many genes like NTRK are now emerging with significant therapeutic utility, but have, again, multiple fusion partners, and it is not possible to detect all of them with conventional methods. An important consideration for you is what should be your minimum expectation from a lab that you send requests for your patient's genomic analysis. I'll talk a bit about this now. So when we talk about labs offering these types of assays, the following are a minimum set of requirements. So that the lab needs to be NATA accredited with robust assay validation, should be participating in relevant QC and QA programs, and should have a robust risk management policies in place, should be able to provide an acceptable turnaround times now, should be following best practice in terms of result reporting, such as international guidelines from AMP and CAP, etc. And obviously, prompt and safe report delivery is a essential requirement. So what questions should you have in mind or should ask the lab that you're considering sending your work to? So these would include what assays are actually lab doing to cater to your set of genes that you require for that patient? How many genes of relevance are present in that assay? Whether these are hotspots or full exonic coverage of these genes are being done. You should be able to ask for a list of hotspots in each gene that is covered, and we have them readily available. An important aspect of successful tumor testing is what type and amount of tumor material is going to be utilized by the platform. What are the turnaround times? Would it cost to get that assay in terms of whether it is MBS item or there will be out-of-pocket cost? And a very important aspect of a good service is a report format. So are the best practice guidelines being followed? What information is being provided apart from variant results? For example, is the interpretation of results being provided or not? How is the report being delivered, whether it will be faxed or emailed, or is there any other method that the lab uses? And at the end of the day, someone at the lab end should be able to answer your questions. Again, an important consideration in NGS is how is the data curated, interpreted, and reported? So checking relevant information for the variants generated through assays require careful consideration of all known relevant databases. For example, in a whole exome setting, there can be up to 5 million variants, and only handful or one of them would eventually be relevant in a particular sample. To help with this, we have many tertiary analysis softwares now available, again with their pros and cons, and not all are equal. And so it is important for labs to know these factors before they decide to go ahead with a particular software. And lastly, just a bit about some of the limitations and challenges that come along with these assays. So we need to know that the performance of a particular assay can be platform and assay design dependent. We know as a fact that NGS assays struggle to screen for areas in genes that have high GC content. There are large deletions and insertion in some areas that are hard to sequence through NGS methodology. Same goes for areas with ITDs. NGS assays can be costly, and this depends on various factors. One of the most important limitations today is whether the assay is attached to an MBS item or not. Assays which do not have an accompanying MBS rebate carry out-of-pocket cost, and this can be a limitation. Again, a very important consideration is the type of tumor material we use. We know as a fact that formalin fixed paraffin embedded tissue, which is what is mostly used for solid tumor sequencing, are really poor in DNA quality. In some of the NGS assays, they struggle with this aspect. So cytology smears, for example, are much better in terms of what they offer for DNA quality. Another challenge that we face with this technology is the amount of data generated. Many times, particularly with larger panels and whole exome and whole genome sequencing assays, it is hard to determine the clinical significance of variants generated. This leads to a risk of overinterpretation, sometimes unnecessary medical action, and also unwarranted psychological stress. And lastly, then, there are challenges which are related to bioinformatics with these assays. A robust evaluation and reporting of variants detected needs exploration of all clinically relevant databases. Now, there is still a lack of databases curated to accept clinical standards, which is a significant hurdle in managing clinically relevant sequencing data. So lastly, there are limitations related to integration into electronic medical records with many of these newer platforms. So this is hot from the press. ESMO released for the first time, a scientific society like ESMO has released their recommendation for use of NGS for patients with metastatic cancers. They released 3 levels of recommendations in August 2020, and they have suggested that routine use of NGS is only recommended for some cancer types, and they base their recommendations on a score that they came up with, which is a clinical actionability score. And they further add that use of large gene panels should be limited to specific setting only. And so this is my last slide of the presentation. So here I've just highlighted various factors that make an assay choice acceptable or not. So there are many factors. Most important ones, for example, are cost, sample requirement, quality matrix offered, types of application possible, and turnaround times, etc. So I'll end my presentation here. Thank you.
Thanks, Vivek, for that overview.